Hello and welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice-changing evidence for the working hospitalist. Today on the show, I'm joined by Dr. Kevin Baker as we discuss faster correction of hypernatremia, whether it's safe or even better, and long-acting antibiotics, specifically Dalbavancin for Staph aureus bacteremia. Well, Dr. Baker, thank you so much for joining me.
Yeah, thanks. Appreciate it.
Dr. Kevin Baker is one of my colleagues and excellent clinical hospitalist, a teacher, a leader, an associate professor of medicine, and a good friend. And I'm so grateful for you for joining the show.
Thanks. That's maybe more of an introduction than I deserve, but thank you. Appreciate it.
Anything else you think the audience needs to know about you?
I got a young family and, just trying to get by while keeping up to date on evidence, which is not always an easy thing to do.
I will make an admission to the audience, as Dr. Baker is well aware. This is actually our first in-person podcast recording. So congratulations to us. Congratulations to Inpatient Update. And with firsts, there come technical issues.
Challenges.
This is take 2. I won't say exactly how far we got into the podcast before I realized that we were not recording. But I'm a solid 90% sure we're recording now. And if not, I'm at least in good company.
Well, whether we're recording or not, we'll have a great time.
Yeah. As a reminder of the format, we'll discuss 2 recent practice-changing articles in less time than it takes you to drink your morning cup of coffee, or in our case, a glass or now 2 of bourbon.
Mm-hmm.
So Kevin, tell me again, what are we drinking today?
This is from a small coastal, this sounds so pretentious, but island near where we live that you can only go to by boat. Had the opportunity to go there last summer, brought a delicious bourbon back with me, and I figured it was a treat. So why not share some on the first Inpatient podcast?
Well, thank you so much, Kevin. And when I was talking to Kevin about potentially being on the show, he said, what you need is a drink. And I was like, oh, yes, you need to be the person on my next episode. Immediately, you have this figured out.
That's why I got the
You
first
understand the Inpatient Update ethos.
I got it.
And so thank you so much for bringing it, and thank you so much for being here.
Sure.
All right, we'll start off and discuss hypernatremia. This was well, Kevin, tell me, have you ever admitted a, say, 70-something-year-old female with some dementia, admitted with a sodium, high 150s, 160s, to the hospital?
Yeah, I mean, we joked about the LOLs, the little old ladies that always come in, and I just admitted one yesterday. Her sodium was, I think, 158, so very recently.
Yep. And so for those patients, we have the general dogma of high to low and the brain will blow. And the rule of thumb is don't correct sodium more than 0.5 millimoles per liter per hour. And this was a recent article challenging that. And so this is an article entitled Fast Compared with Slow Correction Rate and Severe Hypernatremia. It was in the Journal of Critical Care and released in November of last year, 2025. And it sits into a couple of relatively recent articles over the past couple of years looking at this specifically in a few different patient populations. This was specifically ICU patients. It was an observational cohort study with a study design that's referred to as a target trial emulation, which is, not to get too much in the weeds of the stats, but essentially trying to do a cohort study with as much to the close rigor as possible as a randomized control study. But essentially the patient population it's a retrospective cohort study. This study specifically looked at ICU patients. As I mentioned, there have been some other previous studies that looked at more general hypernatremia. But part of the reason I picked this one is because it looks at the sickest of the sick, which I think is an important population because if it works with them, hopefully it works with others. And also it was the most recent of these studies. So in the study, patients who were admitted with hypernatremia, they broke up into both a slow and fast correction group. And this was a matched cohort study. So there were equal number of patients in both the fast and slow correction group.
Mhm.
Fast, they referred to as greater than 0.5 millimoles per liter per hour during the first 24 hours, and slow was less than that, so less than 0.5 millimoles per liter per hour. And the outcome that they looked at specifically in this study was 30-day mortality. And lo and behold, the fast correction group, so going above that dogma level of less than 0.5 millimoles per liter per hour, had a better 30-day mortality. And then also looking at secondary outcomes, had shorter hospital length of stay of 4 versus 5 days, had shorter um, ICU and hospital length of stay both. And so the really the exciting thing about this article is specifically looking at the sickest of the sick in the ICU, but folding into these other couple of recent articles. There was a 2023 JAMA article, which was a large observational cohort study, somewhat similar idea and design, but looking at over 4,000 patients that were on the floor. And also showed that the faster correction had a lower 30-day mortality with an adjusted odds ratio of over 2. And they also notably mentioned no neurologic complications attributed to rapid correction of sodium in that study at all in all of those patients. And there was also another in the Journal of Critical Care, another recent large meta-analysis looking at a bunch of different studies on this topic, relatively heterogeneous studies, but similarly found that there was not any worse mortality with faster correction in that, and that there were the added benefits of reduced length of stay, and there were no major neurologic outcomes related to the hypernatremia. So Kevin, were you aware of this data? Has this been how you've been practicing treating hypernatremia previously, or is this going to be something new and different for you?
No, I think this is pretty game changing for me at least. I work with residents as learners. I work with nurse practitioners as learners, and I think that little lady with the sodium 158 I just submitted the other day, she corrected in 12 hours down to like 145, and I was giving them the old lecture of, oh, this is too fast, you got to slow her down.
Hmm.
And so you presenting this article makes me feel a little bit better about my patient care,
Right?
um the oversight there, that maybe correcting her was actually doing her a favor, not an injustice. But I had learned the same sort of mantra as going slower is never going to hurt anything, going faster could be potentially harmful. Um, I think this sort of challenges that. And to my mind, it makes sense. I mean, is it good for your brain to be sitting in a sodium of 168 for long periods of time, or 158? Probably not.
Yeah, certainly not based on my exam of those patients typically.
Yeah.
Um, yeah, I similarly, to sort of my background of part of why I picked this study, despite it being kind of a weird study design and there being other recent articles that hit the same space, as this was kind of a bit of a pet area of data of mine, dating back when I was a medical student and I was a fourth year AI, and I had a patient that came in, like we talked about, our LOL with hypernatremia, who came in and we had corrected her similarly. I mean, I think something like 16, 20 points overnight in a 24-hour span. And I don't remember if it was we just, it just happened, or if it was a cross cover issue and we gave her D5 water instead of half normal, or we miscalculated her free water deficit, or what it was. But the next morning we saw, whoa, no, we've
Yeah.
over that threshold. This
Yeah.
lady's brain's got to be swollen. And so I, as the fourth year student following this patient, and I'm like running to the patient's room.
Yeah, you're freaking out.
And my upper level's like, go check on this patient.
Yeah.
And I distinctly remember her sitting in a wheelchair in the hall, and I'm in the hallway doing a neurologic exam, looking to see, does she have a blown pupil? Is she able to follow my finger? Like, is she herniating?
Yeah.
And to your point, to this study's point, if anything, she was better. She was more alert, and she's kind of like, what's going on? She, chronic dementia, certainly confused, didn't know who I was or where she was, but was more alert than she had been the day before.
Yeah.
Had perfectly normal neuro exam. And because of that, I thought, okay, interesting. Did we just play with fire and dodge a bullet and get really lucky? Or is there something more here? So I had to do in my fourth year, I had to do an evidence-based medicine presentation, and I selected to do the literature on this at the time. And anything I found back then was essentially there is no evidence that um, there's no evidence that correcting too quickly causes cerebral edema or bad outcomes in adults, but we didn't have the benefit at that time of this evidence that tells us actually we see that there's decreased mortality if you correct quicker,
Right.
and other positive secondary outcomes. And so I found this is like really hits home for me because I think of this as sort of exactly what was wanting to do at the time and was wanting to do with the podcast, and that this is one of the little things that, I mean, you say you saw someone the other day, you see all the time, and there's not like some fancy new therapy. There's not something crazy out there. But as a hospitalist, if we do the little things we see frequently because our reps are so high, if we do those little things well, if we do those little things better, we have a chance to make a significant improvement in outcomes of folks. And I did sort of back of the envelope number needed to treat to have a benefit, and I got 8. So, take it with a grain of salt. It wasn't a randomized controlled trial, but if it's anywhere close to that,
Yeah.
it wouldn't take long for you to have 8 patients with hypernatremia.
I mean, a week on service, I'll probably see 2 to 3
Right.
that are hypernatremic. So it's not good. I'll see that in a month, you know? I always get worried though when I get these folks through the emergency room after they've gotten a fluid bolus, because inevitably they're dry as a chip, right?
Mhm.
And so it's not wrong to give them the fluids, but I used to always get really anxious about them getting the 2 liter bolus. Like, oh my God, are they going to start auto-correcting? The sodium's just going to crash. And I feel like now with this article, I have a little bit of room to breathe. I feel less anxious about it. And now I know I can, if they do start to correct more quickly, I know I can keep going with it because it's safe and actually might help them to correct them a little bit faster. And I was thinking about it, one an hour, like 24 milliequivalents in an hour. Like how many patients are coming in with a sodium more than 164? So I mean, you can just correct them in 24 hours essentially. And
Absolutely.
I'm not surprised that there's decreased length of stay or hospitalization in the ICU. I mean, if you can crank on them and get their sodium back to normal, yeah, I'm sure their brain's going to thank them for it.
Yep. Yeah. And I agree with you. And that really, as much as anything, it kind of removes that fear that I had, that you had recently with your patient, that you have with these dry patients, that I had with that patient back when I was a student, that, you just don't have to worry so much. You can set an aggressive target, hope you hit somewhere in that 0.5-ish range, hopefully over it, go from 0.5 to 1, but don't have to worry if you correct too quickly, because if anything, you're going to have better mortality for folks. And speaking of me as a fourth year AI, this really comes full circle because you were actually the chief resident on when I was the fourth year AI at that time.
Oh man.
And I distinctly remember you orienting me and walking me to the clinical workroom and sort of talking about what it is to be an AI. And I'll probably never forget that you said, AIs are the best thing that ever happened to interns and the worst thing that ever happened to upper levels. And
I
it
can't believe you still came back to work with me after I said that as your chief.
but it's such an insight, and anyone who's ever done the physician training knows
Yeah.
can kind of stew on that and know exactly why that might be the case.
There have been some students that have come up to my wife and had said, like, your husband gave me like a great one-liner, and I always preface it by saying, like, is this going to be a good one-liner or is it going to be a bad one-liner? So thank you for being kind about the one-liner you shared.
No, I should have mentioned in the introduction, honestly, Dr. Baker is probably the one of, if not the most widely well-respected providers at our institution. Kind of everyone has a reason to respect Dr. Baker because he takes good care of patients. He does right by his patients. He does right by the nurses, but he holds everyone to a high standard and he speaks his mind. And I mean, honestly, you garner respect from everyone.
I'm going to take that as a compliment.
All right. Any other thoughts on this article about hypernatremia?
No, this is great. I mean, I think certainly it's going to change my practice. Already has. I had to apologize to the nurse practitioner that was helping me care for that lady with a sodium of 158 already. So never be too proud to say I messed up and there's new evidence and here's what it shows. So definitely is going to change my practice.
Awesome. All right, let's move on.
Yep, I've got a article that I wanted to share with you that I thought of it because I actually listened to your last podcast with Dr. Espina, one of our other colleagues, when you talked about shortening duration of antibiotics. This is called the DOTS trial. Stands for Dalbavancin for treatment of Staphylococcus aureus bacteremia. And basically this is a randomized controlled trial that is open label because the two randomized control arms, the control was standard therapy with IV antibiotics for 4 to 8 weeks with either cefazolin or an anti-staphylococcal penicillin for the MSSA bacteremias, or if it was MRSA bacteremia, vancomycin or daptomycin, versus the intervention, which was Dalbavancin, 1,500 milligrams IV on day 1 and day 8. So Dalbavancin is a long-acting version of vancomycin with a half-life of 14 days. And so those two injections are essentially enough to complete therapy.
Sure.
And eliminates the need for a PICC line or a long-term central access to deliver antibiotics for patients. And so that's why it was open label. You can't really blind people to having a central line. Sure. So this randomized trial took place in 23 centers across the U.S. and Canada. It was from 2021 to 2023, and there were 200 patients enrolled in the trial. 100 were randomized to the Dalbavancin arm, and 100 were randomized to the standard therapy arm. These were all hospitalized patients with complicated Staph aureus bacteremia that had cleared their blood cultures by 72 hours in the hospital and on antibiotics, but had at least 10 days of initial therapy. So they didn't specify necessarily what the therapy was, but that they had 10 days of therapy. They did exclude patients with CNS infection. Mm-hmm. They excluded patients with not right-sided, but left-sided endocarditis, retained infected prosthetic material, or severe immunocompromising states. So as mentioned, they had the Dalbavancin versus standard therapy arms. The primary outcomes that they were looking at was something called DOOR, D-O-O-R, which is the desirability of outcome ranking. And this was checked at 70 days. So this is new to me. I had never heard of this before, but essentially the DOOR, or desirability of outcome ranking, is not just looking at a single endpoint of did it treat the bacteremia or did it not treat the bacteremia? Simple enough question, but real life is way more complicated than that, right?
Sure.
So things that they included in the desirability outcome ranking were clinical success, obviously, infectious complications such as spread to other sites, um, safety complications from the drugs themselves, mortality rate, and then lastly, I think health-related quality of life, which I think was mainly aimed at looking at, do you want to have a PICC line and inject yourself with antibiotics for 4 to 8 weeks? So from those results, they were powered to determine whether Dalbavancin was superior. It did not demonstrate superiority. But in the secondary outcomes, they looked at non-inferiority. And in the Dalbavancin group, there was 73% clinical efficacy, and the standard therapy had 72% clinical efficacy. So the Dalbavancin therapy actually had 1% more clinical efficacy, and based on this was determined to be non-inferior to standard IV antibiotics for 4 to 8 weeks. The microbiological success of it was 98.8% with Dalbavancin versus 96.3% with standard therapy. And in the adverse events category, the Dalbavancin was associated with 40% adverse events, whereas the standard therapy was associated with 34% adverse events. And obviously, when you're giving a long-acting vancomycin that has a half-life of 14 days, there's no take-backsies after you inject it.
Right.
And so you could imagine that you can't really stop therapy, you can't really alter therapy once it's been given. And so I think that this study was powerful, really to me for a very specific population. In this study, importantly, they did include patients with right-sided endocarditis. They included patients that were IV drug abusers. They included patients with osteomyelitis. Um, and so I think this has a place with patients that have inability to give themselves IV antibiotics at home. We have patients that don't have electricity or power, can't keep antibiotics cold.
Sure.
We have lack of funding or medical, literacy and ability to give themselves the antibiotics safely, inability to get the monitoring necessary with many of these antibiotics going in for weekly labs and what have you. And so I think in those patient populations, it's a pretty powerful tool to have in the toolbox. And so I think that that's why I wanted to present this. Antibiotics were getting lesser and lesser durations all the time for various indications. And I think, if you can get away with 2 injections of a long-acting Depo-Vanc and avoid a PICC line in certain populations, it sounds like a win.
Yeah. Super cool. Super cool. Just a quick thought on the methods is that I think the study has a little bit of a PR problem, and that the headline result being that they didn't meet the superiority
Yeah.
outcome. I'm a little bit like, I don't care.
Yeah.
The secondary outcome of non-inferiority from a clinical outcome
Hmm.
is really the headline of the study,
Yeah.
and I look back at the method some to just like make sure that it was powered for that and all of that, and it was quite rigorous in its non-inferiority study. And so I think understandably the authors got excited about like if we can demonstrate superiority,
Hmm.
but really just showing non-inferiority for this is really huge.
Yeah. Yeah. I when I first thought about it, we talked about sort of the physiologic understanding of like changing hypernatremia and like,
Mhm.
oh, too fast has got to be bad. And similarly with this, I was thinking, okay, bacterial static drugs versus potentially bactericidal drugs, like cefazolin or anti-staphylococcal penicillins. Like, of course, you're not going to show superiority unless just everybody's non-compliant with them, right?
Sure. Yeah.
Um, and I think in this case, it's sort of like pushing aside that, oh, theoretical, and it's showing that it's not inferior. And like I said, the clinical efficacy was actually 1% higher with the Dalbavancin. Now, is that that they're just a lot more compliant, or that it's just the two and done, or
Sure.
uh, um, they basically said that if anybody didn't follow up, it was deemed like a failure of treatment
Hmm.
in this one. And so I think that's probably one potential critique on the paper. You can't really have a failure of treatment when you give a depot drug,
Sure.
right? And so maybe that played some sort of role in this as well. But they did separate out the MSSA from the MRSA strains. And there didn't seem to be much of a difference when they did subgroup analysis to see, okay, Dalbavancin versus bactericidal drugs used for MSSA, or Dalbavancin versus bacteriostatic vanc, just traditional IV vanc, or daptomycin for MRSA. So it doesn't seem to, that hypothetical didn't seem to play out in the study. And I agree. I mean, non-inferiority, like, all I care is that it's easier and that it's
Mhm.
not worse,
Right.
you know?
Totally. We can kind of use our clinical judgment to push into that that out the desirability of outcome ranking.
Mhm.
Like part of that is, is it easier for people's quality of
Right.
life? Like we can kind of decide and talk about patients and kind of do that on a patient by patient basis. What I need to know is that it's not an
Right.
inferior treatment.
I think that the authors were expecting more of a signal to come through too
Sure.
when it comes to the health related quality of life, which was one of those desirability of outcome rankings. And it didn't seem like it showed through. And I think, anecdotally, this is my experience. How much of a barrier do your patients put up when you're like, you're going to have to go home with IV antibiotics? And they're immediately like, I'm not doing it.
Oh yeah.
I don't want to
I can't
learn.
do it. I don't know
Don't,
how.
yeah. My daughter is only there once a day. She's not going to do that. And then once you get it in, you get the PICC line in, you get them trained. I think it's less of a big deal than patients put on initially. And so I think that kind of bared out in this paper here that it didn't weigh as heavily as I think the authors thought that it was going to.
Sure.
And I think that's probably one of the reasons why it wasn't really superior to the standard therapies.
Yeah. Every time I discharge someone with IV home infusion of antibiotics, who hasn't been on it before, I give a spiel of like, my partners and I send multiple people home
Hmm.
every day with
Hmm.
this. It's not as big a deal as it sounds. And this kind of backs me up
Yeah.
to your point that, apparently it wasn't as big of a deal as it sounds because it
Hmm.
didn't move the needle much on this general desirability of outcome ranking.
Right.
But big picture here, I'm thinking, wow, what an exciting time we live in when it comes to the treatment of
Hmm.
bacteremia. When you mentioned this article to me, you mentioned how it dovetails in so nicely with the article I talked about with Dr. Ospina, and that article said, you don't need to do 14 days of antibiotics for bacteremia. You can get by with 7 days
Hmm.
for most things, but it specifically excluded Staph aureus
Right.
that we're studying here, and excluded people with complicated
Right.
infections that had
Right.
some sort of lack of source control or something that we were treating other than just the bacteremia. And this hits that population exactly. And in fact, specifically targeted complicated Staph aureus bacteremia. But
Hmm.
I don't have any reason I wouldn't feel totally confident treating non-complicated Staph aureus
Right.
bacteremia if I can treat complicated
Right.
Staph aureus
Right.
bacteremia.
Right. Yeah, I'm less and less finding reasons to put PICC lines in people these days.
Yeah, I think
I mean, by the time you get negative blood cultures, a lot of the times, you've almost treated for 3 or 4 days of antibiotics already.
totally
And so for the prior study you were talking about, Dr. Espina, it's almost a shame to send them home with a PICC line for 3 or 4 days of
right.
antibiotics, right?
Oh, totally.
And then, similarly here, like if you can get away with an injection on day 1 and day 8 of a long-acting vanc, that's awesome. And especially in the patient population I mentioned, people that can't get it, can't afford it, are unsafe with central lines, like people with polysubstance abuse history, or people going to rehab facilities where the rehab facility doesn't want to foot the bill for the Dalbavancin or the daptomycin or whatever it might be. So I think this is a huge game changer for hospitalists who are having to deal with sticky social financial situations.
Certainly. Yeah, we're gonna put our vascular access team colleagues out of business,
Yeah, yeah,
which, like in a sense, a good thing. Only tangentially related. I had a patient that recently was sent to the ICU during a PICC line placement. I
yeah.
mean, it's not. I mean, and that's the obvious like on
Worst
top of the
case,
risk of
right?
infections that but certainly it's not benign, it's not without risk. So if we have another option of something we can do that we
Mm,
know is non-inferior, that's really exciting. Um, and so my question for you is, if it was you who had the right-sided endocarditis and bacteremia, or a loved one, or the osteo or what have you, Would you choose to go the more traditional route, get a PICC, get the IV antibiotics daily, 2 times a day, whatever it is, or would you go with Dalbavancin based on the study?
Man, um, 2 young kids with an IV sticking out of my arm and a dog at home. I don't know, I might opt for the Dalbavancin, to be truthful. I joke and, what if it's a Q8 hour IV instead of a Q12 or
Sure,
Q day drug? I mean, I would have to really think about it. I think, I probably would still recommend if people have coverage, are trainable, good social situation, probably to do the standard therapy. Um, but I would have to really think hard about it. It's pretty tempting to just get a one-time injection in the hospital, come back to ID clinic a week later and get the second injection, and then you're treated.
sure.
Um,
Yeah,
yeah.
I agree. I'm kind of, it now puts it so that it's almost 50-50 for me, and, like, if it's really easy to do the home IV antibiotics and like we talked about, like, it didn't seem like patients cared that much about the difference
Hmm.
based on their quality of life, then I'd probably just err on the side of let's do the normal thing, the classic thing of putting in a pick. But if anyone gives me any reason that it might be beneficial, the fact that I know it's non-inferior is really
Hmm.
helpful, and certainly, like, yeah, same here. I'd seriously think about it.
I did
Uh,
have a recent example where I was getting verbal sign out from one of my colleagues before I came onto service, and it
mhm,
was on a teaching service, and they had a patient that was had a drug abuse history, had MRSA bacteremia, needed to go to a rehab. No rehabs are accepting her because of her drug abuse history, and they were trying to figure out where to put her. And I had just said, "Why don't you just give her Dalbavancin and let her go?" and have the rehab bring her back in a week for her next injection, and then you're good. And the hospitals I was talking with hadn't heard of the study just yet, because it just came out recently. And they called ID that day and actually gave her the injection. She was discharged before I showed up the next day.
yeah.
So it definitely is at least worthwhile asking, I think. I don't know if it's going to be ready for the main stage with infection disease folks, but I think from a hospitalist perspective, it's a great way for helping to solve some of those really difficult problems that we encounter.
Yeah, I think maybe we're starting to see our ID department sort of think about this first, in a lot of patients. I used it a couple of times in residency, and then when I started working at this institution, hadn't really used it since, and it didn't really
Mhm.
seem like it was much of the practice pattern. In training, we used it only in the most extreme cases of basically if someone's like gonna leave AMA, has a history of IV drug use. We
Sure.
don't want to send them with a pick. They say, get
Yeah.
me out of the hospital. We give them a dose and let them run and hope it's good enough,
Yeah.
not having this data to back us up that we
Right.
know it's non inferior.
Right.
But now I feel like our ID department's getting more and more excited about use it. And I similarly had a patient I discharged recently with osteomyelitis who had a little bit of a difficult funding situation and was going to a rehab facility. And we did that just to make it easy on him, to
Mhm.
not have to worry about getting him the vancomycin, to not have to worry about getting him regular level checks. We could just do this once and then again in 2 weeks and be done with it and call it a day. And it made everything easier. And the facility was actually totally on board as long as it was a limited number of doses,
Right.
which of course it is.
Right.
So
Right.
um,
Yeah, and I think importantly in this study, just so people don't think that they're being totally cavalier, it's not like you got the MRSA bacteremia, you clear it, immediately discharge them. I mean, this is after 10 days of initiation of therapy. So
sure,
you've had them in the hospital, you've been checking drug levels, you've been making sure that it's not going super therapeutic, you're making sure they're not having adverse side effects from it. It's not like you're just shoving them with an IV in the ER and saying like, have a great day.
right.
So this is definitely for more of the transition out of the hospital after you've made sure that there's really no sort of side effects or significant adverse events related to the antibiotic therapy. So,
Yeah, to your point, clearly they have to clear cultures and
mhm,
all of that before they roll.
right.
Any other thoughts on this study?
I think pretty soon we're going to be given IV antibiotics for less and less and less time. I think we're just realizing as time goes on that we used to give antibiotics for way too long,
Oh,
seeing way too many side effects, complications of long-term antibiotics. And so I think there's going to be a lot more studies like this coming out in the future.
yeah, that's exciting. So let's recap. First off, when you admit a patient with hypernatremia, um, uh, re- correct their hypernatremia aggressively. You do not need to sort of be gentle and just do zero point 0.5 millimoles per liter per hour. Doing up to 1 millimole per liter per hour, 24 points in that first 24 hours, has shown to have better mortality benefits. So be aggressive when you're treating these folks. And when you have a patient with complicated Staph aureus bacteremia, MRSA or MSSA, it doesn't matter,
Mhm.
and you're trying to get them out of the hospital, think, do I really need to do a PICC line or can I not do a PICC line? Because there is another option you have that is non inferior that requires the patient only to get antibiotic injections every 2 weeks. So, super exciting. Did you have any final thoughts on these studies?
No, I think I just want to say thanks for having me. It's been a pleasure, and I'll have to bring you a different bourbon to taste next time we have another inpatient update.
Oh, certainly. I appreciate it. I've actually graciously gotten 2 different glasses of bourbon given the technical issues, but Dr. Baker, so grateful for you coming on. It's been an awesome discussion, and I hope to have you again.
Thanks, appreciate it.
Yep. And to our listeners, as always, if you're a provider, pharmacist, nurse, resident, or student with any value added insight into the management of hospitalized patients, I'd love to have you on the show. You can reach out to me directly, contact me on social media, or email me at podcast@inpatientupdate.com. Also, certainly subscribe to the show if you find it helpful, rate it, share it on social media, but most importantly, share it with your colleagues. Again, I talked about the number needing to treat being about 8 for that correcting hypernatremia more aggressively. So if you share this with 8 other clinicians, you can sit back and know that you've helped at least one patient. So please share. And thanks so much. I think Dr. Baker and I are going to need to pour ourselves another drink. So cheers.
Cheers.
Appreciate you. All right. Thanks so much for listening. This has been Inpatient Update.